Management of triple or more regarding multiple pregnancy or discordant anomalies. But we're basically going to talk about bichorionic gestation and briefly about triples and more. The epidemiology is well known. When there is a fertilization of more than one oocyte, it is a polyzygotic pregnancy. But if one single mass is divided, then it will be monozygotic. The incidence of multiple pregnancies has increased especially due to reproductive assisted techniques. We used to have an incidence of 1 to 80 elevated to n-1. For example, if we had a triple gestation, the possibility was of 1 in 80 elevated to 2. And if we had a 5-fetus pregnancy, the incidence was of 1 in 80 elevated to 4. And the importance is that they have high rate of perinatal mortality. More or less 70% of pregnancies are bizygotic, and all of them are bichorionic. 30% of them are monozygotic, and of them some are bichorionic, but the majority of them will be monochorionic, or even more complicated. 4 of every 5 will be bichorionic, the majority of which will be bizygotic. But there is 30% of chance of being monozygotic, and 1 of every 5 will be monochorionic, and there won't be any problem with the diagnosis. Regarding the cellular division, if the division occurs in more than 8 days, the pregnancy will be monoamniotic, and if the division is made after 12 days, it is an incomplete division and are Siamese twins, triple, quadruple, etc., are more infrequent. It is important to remember that the zygosity talks about genetics and the chorionicity talks about perinatal risks. Therefore, it is important to remember that the monochorionic gestation have a higher risk of having complications, especially prematurity and severe lesions of the central nervous system. The chorionicity should be diagnosed before the 14 weeks of pregnancy. We have the lambda sign, in which there is a placental tissue separating the membrane. It will be a bichorionic pregnancy, and if there is the T sign, without placental tissue in the membranes, it is a monochorionic gestation. This is an example. This is a triple pregnancy in which we see a placenta, and then we see other placenta, and inside of it we see 2 monochorionic twins. Therefore, it will be a bichorionic pregnancy and other monochorionic pregnancy. It will be a triple, with 2 placenta and 3 amniotic membranes. Dating the gestation should be made with the Mayer CRL. This rule is independent from if it is monochorionic or bichorionic gestation. If the discordance is higher than 50% from 9 to 10 mm, there is higher risk of adverse outcomes. There is a higher risk of aneuploidy, malformation, or even fetal death. But the most frequent complication will be the one in which one of the fetuses develops an EUGR. This in reality is not an indication of karyotype, although it implies a higher risk. It's not the sufficient risk to indicate an invasive procedure. The principal complications of the multiple gestations is the prematurity. This is our data that maybe should be advisable to have it at hand, because sometimes the patient is going to ask, if we have a monochorionic pregnancy, there will be a higher risk of prematurity than the bichorionic gestation. The risk of premature delivery before the 32 weeks is 10% in bichorionic and 50% in monochorionic gestations. And regarding triple gestations, there is a higher risk of prematurity, and higher if there is a component of monochorionic than if there are 3 bichorionic twins. The risk of premature delivery before 35 weeks of pregnancy is 75%, but if it is monochorionic or bichorionic, it will be at least of 50% in less than 32 weeks of gestation. Regarding the chromosomal defects, the risk of chromosomal anomaly is the same in monozygotic than in dizygotic. But it is important that there is a monozygotic gestation. The anomaly in both of them will be concordant. If there is Down syndrome, both will have Down syndrome. On the contrary, in dizygotic, this will be rare. The risk of monogenic disease, as the cystic fibrosis, achondroplasia, will be the same in a monozygotic and dizygotic pregnancy. But we have to have in mind once again that if one of the fetuses have it, the other one will have it as well. Nevertheless, regarding structural malformations, the monozygotic twins have more risk to have one than the dizygotic twins, because the fact that there is a division of a single cell makes that especially the defects of the midline as the heart, central nervous systems are greater. The risk of 15% higher than in dizygotic pregnancies. Remember that in this type of anomaly, it's not the complete concordance, and in just 20 to 25% of cases there will be concordant malformation. This is explained when these structural defects are produced due to chromosomal or monogenic anomalies. When the malformation is post-zygotic, as is the majority due to the environmental factors, it's rare to find concordant malformations. And so, the dizygotic gestation, the risk of concordance is less than 1%. Finally, remember that through ultrasound, it's impossible to establish the diagnosis of monozygotic pregnancies. What we can make is a diagnosis of chorionicity. We know that if it's monochorionic, all of them will be monozygotic. But if it is bichorionic, 85% will be dizygotic, but 15 to 20% will be monozygotic. Therefore, the diagnosis of chorionicity is a must through ultrasound, but the diagnosis of zygosity is made with a genetic test. Let's focus in the bichorionic twins, and when having the death of one of the fetuses, in difference with the monochorionic twin, there won't be a significant risk of concomitant death or severe lesion in the central nervous system of the survivor. Therefore, depending on the etiology, the death of one of the fetuses only will increase the risk of prematurity. This is important because this implies we do not have to make any active behavior towards this pregnancy. We don't have to make any special test, only try to establish the cause of death of the twin, because if it is due to infection, the other twin is at risk, or if it's due to hemodynamic situation, the other twin could die as well. But generally, when there is an unexpected death, the other twin is safe. When we see discordant anomalies in the dichorionic twins, by frequency it will be a selective IUGR, a severe malformation, heart, neural tube defect, or genetic anomaly, as Down syndrome or others. Here we have situations which will condition the obstetrical management. This is an example of a dichorionic gestation with a twin with reduced size compared with its twin, and with a series of anomalies. This other is normal, with its own placenta, and the smallest twin has a central nervous system anomaly, with an encephalocele and a significant cardiomegaly. So, when facing a discordant anomaly, what should be our management? First of all, confirm the pathology and confirm the normality of the co-twin. Generally, it is genetically independent, but there is a percentage of dichorionic twins that will be monozygotic, so we have to confirm the normality of the other. If they have identical gender and one of them has Down syndrome, we have to confirm that the other one doesn't have it. We have to establish whether the anomaly is lethal or not, and inform to the parents the options, and assess the risk of the total loss of the pregnancy and severe prematurity, less than 28 or 32 weeks. If the maternal anxiety dominates the situation, the ideal thing will be to perform an early procedure, better before 14 to 16 weeks of pregnancy, always before 16 weeks. If what dominates is the maximum security of the healthy baby, and the law allows it, then a late procedure will be the best, if the patient tolerates the growth of the fetus with malformation. We should also give the parents the option of organ donation in case there is a lethal anomaly. For example, a couple that had a fetus with a sequence anencephaly, acrania anencephaly carried out the pregnancy till term, and then donated the organs of the fetus that surely was going to die, and is an option that sometimes the parents thanks. How is the selective feticide done? It's an outpatient procedure in which we give an anxiolytic to the mother, and is done with an ultrasound monitor with a spinal needle 20G. We have to accomplish asystolia with the injection of the fetus depending on the size in the heart or in the umbilical cord. The most used is potassium chloride, and after 10 weeks of pregnancy, the dose used is 1 milliequivalent per week, starting from 10 milliequivalents. For example, at 14 weeks, 4 milliequivalents, at 20 weeks, 10 milliequivalents, and at 32 weeks, 22 milliequivalents. If the pregnancy is more than 24 weeks, we will add fentanyl to ensure the fetus doesn't undergo pain, and sometimes we can also inject them with vecuronium to immobilize him and to facilitate the procedure. We also should use ceftriaxone as a prophylactic antibiotic. If she is allergic, then we use clindamycin, and the post-procedure follow-up will be at 3 or 4 hours rest. If she has negative Rh group, anti-D gamma globulin should be administered and relative rest through 24 to 48 hours, but it's not necessary bed rest. The risks? When having a discordant anomaly and doing an expectant management is rare and in a decordial gestation that the healthy fetus dies. The premature delivery before the 28 weeks of pregnancy will be of 5%, but in some malformations such as acrania, which are accompanied by severe polyhydramnios or congenital heart diseases, the risk can be higher, of more than 50%. On the other hand, if we perform a selective feticide, the risk of the healthy baby, instead of being 1 to 2%, which is the basal risk, will be of 3 to 5%. And the risk of premature delivery, if the procedure is done before the 16 weeks of pregnancy, is from 5% goes to 1 to 3%. In conclusion, when performing an early selective feticide, the risk of total miscarriage is a little higher, and the risk of premature delivery lowers. If we perform the procedure after 16 weeks of pregnancy, then the risk of pregnancy loss is higher of 10%, and the premature delivery is also high. We don't improve the risk, we worsen it, so the adverse outcome are increased. Finally, if the selective feticide is done after 28 weeks of pregnancy, the risk of loss of the healthy baby will be very low, and the risk of premature delivery will be the same as the expectant management. In these cases, we have to explain to the parents that it is possible that the patient will begin to have contractions before the procedure is done. Therefore, if the patient lives outside the city, won't arrive in time to perform the procedure, and if the anomaly is not lethal, the fetus will be born and live with the anomaly. If the patients live near the hospital and start to have contractions, then we could perform an emergent selective feticide. Regarding the triple pregnancies, it is widely accepted by parents and doctors to reduce the pregnancy from 3 to 2, and it's due to the high risk of prematurity the triples have. When the selective reduction is done before the 24 weeks of pregnancy, the risk of pregnancy loss increases in 2% more or less. But on the other hand, we reduce the prematurity, as is the triple risk of 25% of delivering before 32 weeks, will be reduced to 10%, if done at 11-14 weeks, and therefore the risk will be comparable with a normal dichorionic pregnancy. The procedure methodology is exactly the same we explained before. But here we have to take into account that the previous villus chorionic sampling doesn't imply a significant risk. Therefore, sometimes it's helpful to perform it, especially if there is a suspicion of chromosomal anomaly in one of them. For example, in fetal reduction before 14 weeks, we will wait till 11 weeks to perform an ultrasound, an early anatomical study, to establish if one of the fetus had a structural malformation. We could also establish an aneuploidy screening with the NT, ductus venosus, tricuspid regurgitation, nasal bone, and very important to remember that there could be the possibility of a spontaneous reduction before 11 to 12 weeks, so wait and be prudent. Regarding the fetus that will be reduced, we will choose the one is more distant from the cervix. Obviously, if there is a chromosomal structural malformation, that will be the one, and we will try to avoid the difficult access and try to enter directly into the sac of the fetus that will be reduced, and avoid myomas or annexual tumors. In some cases, it will be advisable to talk to the parents, the reduction from 3 to 1, to reduce the incidence of premature delivery, which could be in a patient of history of premature delivery or that has a short cervical length. Also, if there is maternal pathology, for example, a heart disease, even we could contemplate the reduction from 2 to 1. And finally, in those triplets, in which 2 of them are monochorionic to avoid the complications of premature delivery and malformations. This is an example in which 2 of them are monochorionic and monoamniotic. We can see how the needle is entering and moving towards the heart. We performed the cardiac injection, instillation of potassium chloride, and here we can see how the asystole is produced. The other monoamniotic twin, for the moment, has positive fetal heart rate, but after taking out the needle from the uterus we will wait, because sometimes the death of one of the monochorionic twins produce the death of the other one. And here we can see how the asystolia of the second is produced as well. Then we have the independent fetus.